Hi again. In the second part of this presentation, we are going to discuss the management strategies of tooth discoloration. The first and the most important step when attempting to treat tooth discoloration is to identify the cause of the discoloration and to eliminate the etiologic factors. So, if tooth discoloration is caused by external stains uh, because of calculus or plaque accumulation on the tooth surface, then toothbrushing and professional tooth cleaning should be enough to treat tooth discoloration. If the cause of tooth discoloration was tooth decay or caries, then management of caries with a tooth colored restoration should be enough to treat the discoloration. Other types of tooth discoloration can be managed by bleaching or tooth whitening, or and this can be done internally or externally, or by enamel microabrasion, and we will discuss these procedures in details. Let's talk about bleaching materials. All bleaching or most of bleaching materials are oxidizers. They are strong oxidizing agents. The most commonly used one is hydrogen peroxide or H2O2. It can be used as hydrogen peroxide or you can use one of its precursors such as sodium perborate or carbamide peroxide. Both will degrade over time, releasing low levels of hydrogen peroxide over a long time. We usually use hydrogen peroxide for external bleaching, in office external bleaching. We use carbamide peroxide for at home external bleaching, and we use sodium perborate for internal bleaching. And they are all they have proved effective. The process of bleaching is an oxidation reduction reaction. The chemicals or the chromogens that cause discoloration are organic compounds that contain carbon bonds or carbon rings. So the bleaching agent or the hydrogen peroxide will oxidize these materials, converting them to uh, molecules that are colorless. So this is the structure of hydrogen peroxide. It's a powerful oxidizer. It has a property of it's unstable. It's very unstable because of the oxygen bond, because of the repulsion between the electrons on the oxygen atoms. So it's considered as a free radical that will degrade quickly if exposed to light or heat, uh, providing or forming water and single oxygen molecule that will start another reaction. Carbamide peroxide is a precursor for hydrogen peroxide. It disintegrates to produce urea and hydrogen peroxide. It is available in different concentrations. Every 10% of carbamide peroxide will break down to provide 3.5% of hydrogen peroxide, and this is an important percentage. So every 10% of carbamide peroxide will produce 3.5% hydrogen peroxide, in addition to other compounds like urea, ammonia, carbon dioxide. Sodium perborate, it's usually available in the form of powder that can be mixed with acid or with water. Then it will decompose to produce sodium metaperborate, hydrogen peroxide, and oxygen. As we mentioned earlier, it is used for internal bleaching because it's safe and it can be easily controlled, and the reaction occurs slowly and gradually, releasing low levels of hydrogen peroxide over a long uh, period of time. Now, as we mentioned earlier, bleaching can be done internally or externally depending on the cause of tooth discoloration. We can choose one of these techniques or both. Internal, or the other name is non-vital bleaching, which means that internal bleaching can only be done if the tooth is root canal treated. It can be done using different methods like the walking bleach or thermocatalytic technique or the inside-outside bleaching technique. Let's talk about the walking bleach technique. From the name, as the name indicates, the bleaching material is applied inside the tooth, and then the patient will be sent home, then sent back home, and then they will be reviewed over or after a few days to apply another fresh mix of the material, and the treatment can be repeated for as many times as the discoloration needs uh, until the patient is satisfied with the result. Then the bleaching can be stopped and a restoration material can be applied. So the first step is diagnosis and knowing the etiology and the origin of the stain. If it's intrinsic, then we can treat it with a walking bleach technique. We have to check the root canal treatment of the tooth. If it's sufficient clinically and radiographically, we have to check that there is no or there are no signs of infection or inflammation, and there are no signs of periapical pathology on radiographs. We have to check the quality of the coronal restoration, because sometimes if there is leakage from the coronal restoration, this will lead to a failure of the root canal treatment. Once the root canal treatment's been checked, then we can take photographs of the teeth to record the shade before the treatment, along with a shade guide. This procedure should be done under rubber dam isolation to prevent contamination of the pulp space and to prevent failure of the root canal treatment. Then we remove the excess root filling material in the pulp chamber. We should clean the pulp chamber completely from sealer, root filling material, irrigate the pulp chamber. After that, we reduce the gutta percha or the root filling material to about 2 millimeters below the cemento enamel junction. And we can verify this by using a periodontal probe. So we can use it inside the tooth and outside the tooth to check the level of the coronal or of the root filling, the coronal extent of the root filling. We can use a slow speed long neck round burr to reduce the root filling material. The root filling material, gutta percha and the sealer, does not provide a seal against the penetration of the bleaching material to the root canal. Therefore, we should apply a restorative material like IRM, cavet, or composite, or glass ionomer to about the level of the cemento enamel junction. So we reduce the root filling 2 millimeters apical to the cemento enamel junction, and then we fill the 2 millimeters apical to the cemento enamel junction with glass ionomer or resin restoration or cavet or IRM. Then we apply the bleaching material inside the pulp chamber. We usually apply the sodium perborate, which comes as a powder that is mixed with acid or with water, and then we apply it, and then we seal the cavity with a temporary restoration. The thickness of the temporary restoration should be enough to prevent coronal leakage and to prevent leakage of the bleaching material outside of the pulp chamber. The rubber dam is removed, the tissues inspected, and then the patient is instructed to return for a review visit after 3 to 10 days. Then the patient also is instructed to self-monitor the shade of the tooth so that they can identify or know if they have reached to the required shade or color of the tooth. This procedure can be repeated over multiple visits. So if the patient comes in after 3 days and the color of the tooth hasn't reached to the level that we want, then we can wash the bleaching material and then we can apply a fresh mix, because if we leave the old bleaching material, it won't, for a longer time, it won't add anything because the material would have been exhausted and consumed. So we have to wash the previous bleaching material and then we apply a fresh mix of the active ingredients of the material. We can repeat this procedure over multiple visits until we are satisfied with the results. So on these photographs, you can see that the patient is suffering from discoloration of the mandibular right central incisor, most likely because of leaving root filling material inside the tooth or inside the pulp chamber. The rubber dam isolation has been applied. The level of the gutta-percha and the root filling material has been reduced to around 2 millimeters below the cement to enamel junction. A 2 millimeter thick layer of resin or glass ionomer or IRM has been applied, and then the sodium perborate has been mixed with acid or with water and then applied to the pulp chamber, which is sealed with temporary restoration. The patient has been reviewed after 1 week. We haven't got the result that we want. Then another mix is applied until the patient is happy and satisfied with the treatment. So if you look at the root canal treated tooth, you will have the root filling in the root. Then the root filling should be reduced to around 2 millimeters below the cement to enamel junction. Then you have a 2 millimeter thick coronal barrier. Like this, you can use IRM, cavit, resin, or glass ionomer. And then we have the bleaching agent and then a temporary restoration. The walking bleach technique is very effective and it's safe to use and it requires the least chair time. So the patient will not sit on the chair for a long time. We just apply the bleaching material, send the patient home, and then review the patient after 3 to 10 days. Now, the second method to apply the or to do internal bleaching is using the thermocatalytic technique, and this technique is not recommended anymore because in this technique we use high concentration of hydrogen peroxide ranging from 30 to 35%, and then the material is activated using a heated tip or special lights to accelerate the reaction. And actually, because of the high concentration of hydrogen peroxide and because of the heat that's applied, this was shown to result in invasive cervical resorption. That's why we should avoid this technique. The third method is to apply the bleaching agent inside and outside the tooth surface. Now for this technique, the restoration in the access cavity should be removed completely under rubber dam, of course. and then the pulp chamber should be cleaned. The gutta percha should be reduced to about 2 or 3 millimeters below the cemento enamel junction, and then we place a 2 millimeter thick coronal seal using glass ionomer or resin restoration or IRM or cavit. And a special tray is fabricated, a bleaching tray is fabricated, which allows the patient to apply the bleaching gel inside the access cavity and outside the access cavity. So the access cavity will not be sealed in this technique. So, and the patient is instructed to apply the bleaching gel inside the access cavity and on the bleaching tray, and to wear this tray for all the time except when they are eating. And the bleaching gel should be changed every 2 hours, and it should be worn overnight as well. We advise the patient to change the bleaching tray so that we can get a fresh mix of the material every 2 hours, because the material will have been consumed. In this bleaching technique, we usually use 10% carbamide peroxide, and we give that to the patient because it's safer. Because hydrogen peroxide, it's caustic and it can cause burn of the soft tissue. Carbamide peroxide is easier to control and it's safer. Once the patient is instructed to apply the bleaching gel until they are satisfied with the results, and the patient should be reviewed every 3 to 10 days. And once the patient is happy with the result, then the access cavity should be cleaned and sealed with a permanent restoration. Now, as you can see, this technique requires compliance of the patient. That's why you should select your patients. If you are going to use this technique, you should make sure that the patient is going to follow the instructions. And sometimes food will get accumulated inside the access cavity, and that will result in reduced efficiency of the treatment because the bleaching gel will not be in contact with the tooth surface. We usually tend to over bleach teeth uh, because of future recurrence and relapse. So we usually tend to go 1 or 2 shades lighter than the patient's teeth, because the treatment, there will be a relapse in the treatment. Now, extrinsic discoloration should be managed by external bleaching. And external bleaching or extrinsic stains are more easy to get rid of than internal or intrinsic staining. For external bleaching, we can use in-office techniques on which the soft tissues will be isolated, and then we choose the shade of the teeth preoperatively, and then we apply the bleaching gel on the external surface of the teeth, and then we use certain types of light to activate the bleaching gel, um, and that's the in-office bleaching. And then we can also supplement this bleaching technique with at-home bleaching technique, on which we take an impression for the teeth, and we on the cast we apply the spacer. So this blue color is a spacer to act as a reservoir for the bleaching gels, and then we make a special bleaching tray for the patient to apply the gel inside and to wear. The mechanism at which the bleaching agent will work is an oxidation reduction reaction. As we mentioned earlier, the hydrogen peroxide is a strong oxidizer, and it is a reactive oxygen species that is very unstable and will attack the organic molecules that are responsible for tooth discoloration. Hydrogen peroxide will attack the pigmented organic molecules, the chromophores, and will break them down by the action of free radicals. And it will produce simpler products that are colorless and will reflect less light. So, if the chromophores or the chromogens are carbon ring compounds, they will be converted to carbon chains and double bonds, and it will also break the double bonds, converting them to hydroxyl groups, which are colorless. It will also reduce the colored metallic oxides. It will react with metallic oxide, producing colorless materials. And this is the reaction. So as you can see, if you have a highly pigmented carbon ring compound, it will interact with hydrogen. The hydrogen peroxide will attack the ring, converting it to carbon double bond chains, which are yellow and lighter in color than the carbon ring compounds. This will further interact with hydrogen peroxide, producing single bonded compounds and colorless hydroxyl groups. Now, when managing tooth discoloration, we should go in an order. We should use the least invasive techniques, and then if these doesn't work, then we can move into more invasive ones. So the least invasive and the most conservative technique to apply is to whiten the teeth or bleach them. If that doesn't work, then we can use the microabrasion. If that doesn't work, then we can move into composite restorations. If they don't work, then we can use veneers and crowns. The advantages of tooth whitening, as you have seen, it is very conservative. It's more conservative than restorative methods. It's relatively simple. They are less expensive than restorative procedures, and there will not be an irreversible damage done to the tooth or to the crown or the root of the tooth if the right technique has been used. Now we have talked about tooth whitening or bleaching. Let's talk about microabrasion techniques. Microabrasion, it means that we apply an abrasive materials mixed with an acid to remove a minimal amount of tooth surface, to remove the discolored part of the tooth surface. So we usually we take photographs of the teeth to be treated with microabrasion along with a shade guide to record the shade. Then we apply gingival protection materials such as rubber dam, and we fill the spaces with a light cured or chemical cured gingival protection materials. Then we use a pumice, which is abrasive material. It comes as a fine powder. We mix it with 18% HCl or hydrochloric acid to form a paste. Then we make another mixture of sodium bicarbonate mixed with water, and we leave it to the end of the procedure. We apply the first mixture, which is hydrochloric acid and pumice, to the tooth surface, to the enamel surface, and then we use rubber cups or brushes to clean and remove the superficial layer of we scrub the surface and to remove the superficial layer of enamel, and this motion is done over 5 seconds for each tooth. Then we rinse the surface with water, and then we can apply the mixture again if needed. After we finish the treatment and we got the result we want, then we use the other mixture, which is the sodium bicarbonate with water, to neutralize the reaction, because bicarbonate is a base, so it will neutralize the HCl. Then we remove the rubber dam. So this is a photograph of a patient who suffers from mild fluorosis in the incisal and middle thirds of the incisors. The mixture of HCl with pumice has been applied to the teeth, and of course, you can see the rubber dam isolation. A rubber cup is used to rub the material into the surface. Once we got the result, we apply the bicarbonate with water mixture to the surface to neutralize the reaction, and this is the final result. Um, Microabrasion, it's not considered as a bleaching or oxidation reaction. It only decalcifies and removes a thin layer of stained enamel. So as you can see, it's still more conservative than the restorative procedures, but it is more invasive than bleaching. And it's proved to be effective when used for the right cases, such as cases with mild fluorosis. It's very important that we apply rubber dam isolation to avoid burning the soft tissues with the HCl acid. And it's also important to avoid applying too much pressure or leaving the material for a long time over the teeth to avoid excessive decalcification of enamel. There are certain laws or rules to regulate the use of tooth whitening and bleaching. For example, in the European Union, the maximum amount of bleaching or hydrogen peroxide in the bleaching gel should not exceed 6%. So, or if you are going to use carbamide peroxide, you have to multiply 6 by 3.5, and you shouldn't use any material that releases more than 6% H2O2. Although this is not applied in all the countries, like in the US, you can get higher concentrations, and I think here you can get higher concentration. Tooth whitening should not be provided for patients under the age of 18 because the pulp chamber will be large and there will be a chance to irritate the pulp. And tooth whitening should not provided or should be provided under the direct supervision of a dentist. So it shouldn't be provided by people who are not healthcare professionals. What are the side effects or the complications of tooth whitening? As we mentioned earlier, it can cause external root resorption, especially if we use the thermocatalytic technique or high concentrations of hydrogen peroxide along with heat. We also can get chemical burns for the soft tissues, the gingiva or the lips, if the rubber dam isolation or the gingival barrier was not applied correctly. And these can last for days and then it will return back to normal. There are also some studies suggesting that the bleaching material can change the physiochemical characteristics of dentine and enamel, resulting in reduced strength, or they become brittle and they can fracture. But this has not been proven conclusively. And obviously, of course, tooth whitening will result in increased sensitivity in the teeth. Now, to reduce the sensitivity and the discomfort from sensitivity, we can ask the patient to use desensitizing toothpaste, such as Sensodyne or other toothpastes that have high amount of fluoride or potassium nitrate, to apply it in the bleaching gel, in the bleaching trays, and to wear them. And we should also advise the patient to reduce the consumption of colored food and drinks that can stain teeth. And if they have to drink these, they can use a straw, especially in the first 2 days. Patients should also be encouraged to visit the dentist regularly for checkups and to maintain good oral hygiene. And a very important note that composite restorations or adhesive restorations should not be placed on bleached teeth immediately. We should wait for 2 or 3 weeks before applying or putting the final adhesive restoration, because hydrogen peroxide will produce oxygen, and oxygen inhibits the polymerization of resin. So that's why we should keep like a waiting period between the bleaching and the final restoration application. Well, thank you for your attention.